Do 1, 2, test, test, test. Test 1 2 1 2 test test test.
They mess with me every time I will or till it happens. I always do.
Test 1 2 1 2 test 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 test.
Whenever you're ready.
Are y'all ready to get started? Can everybody hear me okay? I appreciate y'all being here. Today is the makeup day for the last Tuesday in January snow that didn't happen. So we're going to talk today about sepsis. It's going to be pretty informal, yet informative, I hope. You can ask questions during, or if you want to save them up till the end, that's fine. It should take about 20-30 minutes to go through the slides, and then we can have lots of time for questions if you want, or comments, or even suggestions. Sepsis is a hot topic. As you'll see, not everybody can really agree on all the definitions. They can pretty much agree on the general definition. Sepsis is a syndrome of life-threatening organ dysfunction due to a person's dysregulated response to infection. Beyond that, it's hard to get people to agree on a lot. However, they will agree on the fact that sepsis is the final common pathway for how infections cause death, which I think is an interesting way to look at it as well. We'll look at some numbers for a minute just to give you an idea of the scope of sepsis. In the U.S., there are approximately 1.7 million cases of sepsis every year. And we think that sepsis contributes to an estimated 265,000 deaths each year. It's a lot. It's a significant problem. And I think as the population ages, we're probably going to see these numbers go up. If you start reading much about sepsis, if you start doing much in the way of investigating, you're going to see how the definitions have changed. And in fact, I have one part of my bibliography with me that has a table, a reference table from 4 different expert sources with 4 different sets of definitions. So getting to a consensus has been difficult. I think we as an institution need to find what works for us that's within a reasonable set of parameters, and I think we have to find what works for our patients. But just realize that the definitions have undergone evaluation and they'll probably change again. Nobody can really figure out the best way to word what they want to say in order to provide the best sensitivity and specificity. In other words, especially early on when somebody's sick is coming to the emergency room, you want the right set of criteria so that you catch the right patients, you capture them early, you appropriately identify them as patients that are at risk for sepsis without dragging in too many patients and treating them unnecessarily with antibiotics when they should actually not be captured for sepsis. So the definitions are more important than you might think, but also a little bit more difficult to clarify than you might realize. We have an ongoing sepsis initiative here. A lot of people are currently participating in it. One of the things that we're trying to do is to improve the sensitivity and the specificity of identifying patients and treating them early. And we want to also be able to demonstrate measurable improvements in outcome. And I think we'll be able to see that more in the future as more data are collected. You all hear the code R sepsis called. It's something that we rolled out in November. It's a tool that we're using, and what we're trying to do with it is to promptly identify patients with sepsis and to begin appropriate treatment quickly. There's been some discussion about whether this should be house-wide, whether it should be included in the ER or not, but regardless of how you feel about the code R sepsis, I think it's worked, and I think it is working, and I have some numbers toward the end that I think will prove this, and I hope that in a few months we can look back at the data that's being generated now and show that it's improved our outcomes. Our sepsis team is actually due for a follow-up meeting soon to assess where we are and to see where we need to go. If anybody has any thoughts or comments or suggestions today, please feel free to speak up. When we meet, we'll see if there are things that need to be incorporated that we're currently not doing, or things that we're doing now that we could probably remove from our current initiative. So what I want us to do today is to look at our initiative, look at the most effective components. I want us to always be focused on patient care and be able to prove that we're providing the best care and that we've got the improvement in outcomes to definitely demonstrate that. I tried to put together a list of people that have participated in this. Leanne helped me, and basically we just listed everybody in the building. It includes people from quality, nursing, lab, the pharmacy, the medical staff. Certainly our infection control practitioners are key participants. But even people that you may not credit with participating in something like this, nutrition services, environmental services in particular, are key components of the sepsis team. If you think about the environment of care, it's vital with regard to sepsis in particular and C. diff especially. And we always have to have administration support to have our initiatives be successful. And so today I'm just going to kind of give you an update on where we are. And we'll talk about sepsis in general. We'll talk about which antibiotics we're using and why, and you can formulate some questions. I like this slide. This is from a recent article in Clinical Infectious Diseases. And it really helps define what I get to do all day, every day. I get to look at pathogens. I get to look at patients, at hosts, think about how patients are susceptible to various pathogens, the factors that influence both sides of this equation. I have to decide if I think infection is present or not. I have to decide if I think sepsis is present or not. And I get to intervene and hope to avoid death. But one thing I do want to point out on this slide, a pathogen is not identified in at least 50% of sepsis cases. And that's frustratingly true. And patients, I think, have a hard time understanding or believing or accepting that we can have what we think is a pretty sophisticated system and yet not be able to identify an organism when someone has life-threatening sepsis, not be able to identify an organism in over 50% of cases. We're going to talk a little bit about the core measure bundle. Please don't fade off because I just said bundle. We'll try to realize why this discussion is important and also realize that we're not really welded to bundles, that these are some things that are going to be fluctuating in the future. The core measure bundle was introduced by CMS in 2015 in October of that year. What they're doing is trying to help recognize early patients with sepsis so that treatment can begin early. And you'll hear about 3-hour and 6-hour bundles, and that's because they were trying to narrow it down to aspects of care and aspects of treatment intervention within 3 hours and within 6 hours that could be shown to reduce mortality. And for example, the one that I think is probably the most striking and the most memorable is the fact that within the first 3 hours, if you give antibiotics, you've got a demonstrable improvement in mortality compared to when antibiotics are delayed. So that's kind of where the 3 and the 6 hours fell out and why you see 3 and 6 hour bundles. CMS used some definitions early. These are the ones I tend to use. They may change in the future. Sepsis itself is a life-threatening organ dysfunction caused by dysregulated host response to infection. Septic shock is a subset of sepsis, where you have profound circulatory, cellular, and metabolic derangements. Specifically septic shock, someone has to have shock that requires IV fluid administration, IV fluid resuscitation, or a serum lactate that's 4 or greater. I've included in here a sentence saying the inconsistencies between regulating authorities and guidelines are confusing. Well, they are confusing. And I've got some references if you want to read them. Just one, for example, is a statement from the Infectious Disease Society of America saying why they did not back and endorse the guidelines from the Surviving Sepsis campaign. So even the experts, even the ivory tower people that do this 24/7 don't agree. And I'll try to help us arrive at some definitions and some working guidelines that are going to help us day to day. And for that reason, I put on here that when I see folks in the hospital, I tend to stratify them in my mind, and both for record keeping as well, sepsis, severe sepsis, and septic shock. Sepsis, for example, somebody I just saw with C. diff, severe sepsis, C. diff with evidence of organ system dysfunction, and septic shock, I'll scan the chart for a lactate or hypotension or pressors. And it's usually, this is a decision, a stratification you can make actually reasonably quickly. The 6-hour window, all the criteria must be met within this time. 2 or more SIRS criteria, 1 or more evidence of organ dysfunction in 1 or more organs, and documentation of infection by the physician or the licensed independent practitioner. The SIRS criteria, just to reiterate them, to repeat them, temperature greater than 38.3, less than 36, heart rate above 110, respiratory rate greater than 22, white count above or below a certain limit. For organ dysfunction, all the criteria with which you're familiar: low blood pressure, acute respiratory failure with new need for invasive or non-invasive ventilation. I've already mentioned the lactic acid for severe, for SIRS, for systemic inflammatory response syndrome. Lactic acid greater than 2. For septic shock, it's 4 or greater. The renal criteria, also the hepatic and hematologic. And as I just said, severe sepsis, septic shock with lactic acid greater than or equal to 4. Some things that I think we forget, and sometimes I have to call Lacey, who is our quality sepsis go-to person. I forget that in giving antibiotics and getting cultures, in doing what I'm doing and making sure I'm not leaving something out, that the guidelines also recommend following lactate if the initial is above 2, and the goal is to get it below 6, I think within 6 hours. But this is also an important parameter that I think we need to remember to check. And we'll talk about that later on, but this is sometimes something that's keeping us from meeting all of the criteria. So checking lactate, checking blood cultures, I think that's something that's a little bit easier to remember. Administering broad-spectrum antibiotics. The pharmacy has been real helpful, and nursing has been real helpful, because actually, to clinicians, it doesn't make sense that a certain antibiotic has to be given before another. Just accept the fact that it does, and that the pharmacy is going to help you take care of it. The other thing that has been a little bit difficult for people to wrap their heads around has been the fluid requirement. I think it'll probably change in the future, but at this point it's 30 cc's per kilogram within a reasonable time. I think 2 to 4 hours is probably what's required to meet this bundle. That's a lot of fluid. If somebody is overweight and you document that they have morbid obesity, then you can in fact use their ideal body weight. But that 30 per kilo of fluid over 2 to 4 hours is a pretty hefty dose. So stay tuned and we'll see if that gets updated or changed at some point. Yes, Laura?
Has the team considered using central venous pressure as part of hydration?
I know that that's part of what's talked about in guidelines. I don't know that we've discussed specifically using CVPs. I think they could be very helpful. Leanne, do you remember if CVP utilization has come up during any of our meetings so far?
At this point, we are not doing it from what I understand at this facility, and I don't know that it's going to be.
I don't know that there's any impediment to doing it. I just don't know that there's any drive to do it right now, but it's certainly something that we could look at, yes. Initial hypotension is defined as 2 low blood pressure readings from different sites, 6 hours before or 6 hours after the presentation. And as I said, you can use an ideal body weight if you need to. Repeating the initial lactic acid, repeating it if the initial result is greater than 2 is important. Following it to make sure it's going down and not up. Keeping a mean arterial pressure 65 or 70, systolic blood pressure about 90. Those are parts of both bundles. The tissue perfusion assessment is something I know that we have fallen out of, not infrequently, but basically documenting tissue perfusion with exam and some of these parameters, arterial oxygen, capillary refill, peripheral pulse evaluation, and being sure to say, exactly where, not just peripheral pulses 1+. And Laura, the CVP recommendation is here. And yeah, I think it is something that we could use for whatever reason we haven't, but I don't know of any specific reason that we have not. The other thing that's important after assessing patients, the other part of this treatment paradigm is selecting initial empiric antimicrobial therapy based on your local hospital's susceptibility patterns. Speaking of which, we look at our antibiogram every spring. We'll be looking at it soon. We'll make sure it's available somewhere on the computer for access anywhere. Basically, our 2 workhorse antibiotics are still vancomycin for gram-positives and Zosyn for gram-negatives. Having said that, I'll go through some of the guidelines that Ascension has come up with in these power plans. This is the power plan for urinary tract infection for pyelonephritis. It's got complicated UTI with low risk for resistance, high risk for multi-drug resistance, and then complicated UTI with documentation of, for example, ESBL-producing organisms. And basically, these rely heavily on third-generation cephalosporin, ceftriaxone with quinolones with documented allergy. And then as you get into patients that are at risk for more resistant organisms, you're going to want to use something like meropenem initially for empiric therapy. In a similar fashion, the community-acquired pneumonia power plan has ceftriaxone, azithromycin early on, and for the inpatient ICU, also ceftriaxone with intravenous azithromycin. Then the hospital-acquired or ventilator-associated pneumonia, pip/tazo or cefepime. You can use meropenem if there's a risk for resistant gram-negative rods, and then if you think that your patients at risk for MRSA pneumonia, you can add vancomycin. The intra-abdominal treatment, antibiotic selection, also relies heavily on third-generation cephalosporin, ceftriaxone, with or without flagell. As patients get sicker, or you think they may need broader coverage, adding flagell to gram-negative coverage, and then also, if needed for the sickest patients, for MRSA coverage, adding vancomycin. Also, similarly, skin and soft tissue, relying on first-generation cephalosporins for initial treatment, and then going to antibiotics with broader spectrum therapy for those that are more ill. And the same for febrile neutropenia, cefepime or Zosyn, with meropenem if needed, and vancomycin if MRSA is suspect. I referred to this earlier. Basically, CMS has appropriate monotherapy options, including cefepime, ceftaz, ceftriaxone, and Zosyn. If your sepsis patient is coming in and being given vancomycin and Zosyn, and you give the vancomycin first and the Zosyn doesn't go in within a quick enough period of time, you may fall out of the measure. You may not meet the measure because of that. So the Zosyn has to be given first. It doesn't make a lot of sense to me, but that's the way it is. But the pharmacy and Leanne, is nursing also on the lookout for this?
They have been educated, and all the pharmacists do know how the monotherapy should be administered, and we are entering those orders to meet those monotherapy.
Okay. So since I don't know which order antibiotics are supposed to be given in, I rely on the pharmacy to take care of that for me. The other thing that's important, and one of the things that we're trying to be a little bit more aggressive with, is daily inspection of antibiotic therapy for de-escalation or discontinuation. Some people are actually calling it an antibiotic timeout, which is being done at 48 or 72 hours. I think it's important, and I think it's something that we're going to be seeing more of. I think if cultures are negative at 48, 72 hours, then de-escalating or discontinuing antibiotics is standard of care, and I really don't see, I have not seen where any patient has suffered harm because of that. Now, I guess the other thing that plays into this that's worth mentioning now is some additional lab technology that we hope will be available that will help us identify pathogens more quickly and more accurately. And I think that will help us be a little bit more aggressive with this antibiotic timeout. We're going to talk a little bit about mortality reduction and bundle compliance. Fiscal year 2019 is July 1 through June 30th, this upcoming June 30th. So Ascension wants us to reduce sepsis mortality by 10%. Across the board, that would save 350 lives, but in Alabama alone, if we met this goal, it would save 34 lives. When we're reading about this target rate, this is the rate of observed over expected deaths due to sepsis in our defined area. So, for example, the Alabama target rate is 1.28. Currently, we're at 0.995. For St. Vincent's East, our target for this fiscal year is 1.72, and currently we're at 1.77. So we're doing well. I don't have mortality data yet that is more specific than this. I don't have it month by month or week by week yet. I hope that the next time I give an update, I'll have a little bit more precise breakdown of our mortality data, but basically we're doing better. This is to remind us that CMS has been publicly reporting the sepsis bundle compliance since July 2018. St. Vincent's East ended the previous fiscal year with a bundle compliance of only 25%. However, as of this past December, and we're now in fiscal year 2019, our bundle compliance had gone up to 66%. So we're doing better. And I plan to come back our next update and show you how mortality has gone down. Ascension has given us standardized order sets. They've given us sepsis education. We have our sepsis team, and we have the Code R sepsis, that I think all of these individual elements are helping us meet these goals. Some people have not been particularly supportive of the Code R sepsis. I think it's helped. I've been very much behind it. We started at November the 14th, and just in that first month, we had 71 patients with a sepsis diagnosis, and 42 appropriately completed the bundle. And that was a 59% pass rate for the hospital, which is a great improvement. And like I said, I hope to bring some mortality data soon and show you that we really are reducing mortality as we're demonstrating adherence with these bundles. If I'm not mistaken, this is my last slide. It shows opportunities for improvement. In other words, these are places where we have fallen out of the measure. Repeating a lactic acid after, Leanne, is it 2 or 4 hours? Repeating a lactic acid after 2 hours, giving the right antibiotic within the right period of time, and also blood cultures. The exam portion of this has been referring to the exam for tissue perfusion, and then the fluids has been a big problem. We're trying to address it. And Laura, maybe you're right. Maybe we should be using CVPs and not being quite so reluctant to give the recommended amount of fluid. But I also think we need to watch out. I think that that recommendation is going to be updated probably soon. What questions do you have? What comments do you have? How much do you enjoy Code R sepsis? Yes?
Do you have any comparisons with the university?
No, we don't. I don't have access to their data. All we have access to is Ascension data. And I think as time goes on, they're actually sharing more and more across other fields. And I think that comparing ourselves to other Ascension hospitals is probably more appropriate than comparing ourselves to a university facility. But in future updates, I'll try to give you more of a comparison with other Ascension hospitals. Other questions, comments? All right, thank you very much.